All right, thank you, everyone. My name is Clara Lambert, and I'll be moderating the session with lots of questions. Hopefully, we'll have time for questions from the audience afterwards. But we're going to be talking about building relationships between industry and navigation, and just to better ensure patients' access and adherence to treatment. So to get started, my name is Clara Lambert. I'm an oncology financial navigator by trade. I've been doing it for a very long time, and I'll just kind of leave it at that. I've worked in a couple of large healthcare systems in 2 different states, and now I work for a technology solution that facilitates financial navigation. And so I just want to pass it along. We have 3 panelists with us, and I'm going to let them each just introduce themselves and a brief overview of who they're representing for our panel.
Hello. Who gave this girl a mic? My name is Lacey. If I don't know you already, it's nice to meet you all. I have been in the private practice sector for about 9 years now, and I come from the asthma and allergy side of healthcare. I also serve as the vice president of the National Association of Medication Access and Patient Advocacy.
Hi, I'm Melanie Woodland. I'm an oncology financial navigator, I guess, still. St. Alphonsus Health System, which falls under Trinity Health. I'm in Boise, Idaho, and we have Idaho and Oregon. I was in the Air Force prior to that, and so it's been about 10 years now. I moved into revenue cycle in a nonprofit healthcare setting, and then oncology or hospital-administered drug infusion injection space I've been doing for about 8 years now.
Good afternoon. My name is Josh Berggren. I'm with Pfizer. I've been with Pfizer for quite a while, and my current role is Director of Patient Advocacy and Professional Relationships, so working with patient advocacy groups at the national level to foster collaborations and innovations to support their work as well as our work in hoping to simplify the complexities of care. Prior to this role, I was an FRM with Pfizer Oncology for about 5 years. So the last 10 years of my career have been in the access and reimbursement space or the advocacy space. So nice to see everyone today, and thank you for having me.
Thank you, everyone. All right, so just a quick agenda. We're going to talk about understanding the role of industry in patient care, overcoming barriers to treatment, leveraging the patient support programs, improving treatment adherence, strategies for building industry relationships, and future opportunities. So, just setting the stage for understanding the role. If we'll start with Lacey and Melanie, I think I'm going to put 2 questions together. First of all, just give us a brief overview of your background and experience in industry relationships. And then also the 2 of you are, one's from healthcare system, one's from provider practice. So if you can tell us a little bit about the difference between the 2 of your roles. They're similar but different, so it's important to know.
Sure. So I guess you would say I was a biologic coordinator by trade. I actually started my healthcare career as a nurse in more of the oncology and radiology side, if you can kind of imagine those meshed together. I was a breast cancer navigator. So that's where I started my career, and that was, I don't want to age myself, but more than 20 years ago. So it's been a minute. And then I actually really just had a lot of respect for my director and followed her over into the asthma and allergy field, which was a whole new ballgame for me, but I learned to love it. Absolutely adore it. And so biologic coordinator, that whole medication access in the private practice is really where I guess you'd say I stem from.
So I was in patient access in a hospital setting, and we have patient advocates, like most nonprofits especially. We didn't have anybody that could work oncology specifically and all those programs, so I helped write that job description and started from scratch and moved into that role as a coordinator from a manager position, and we had no history of this role in our health system. So I started with nothing, like no person to ask questions to, and that's when actually the social worker that was leaving oncology gave me bags and bags of all the material that pharma partners had left of all their different patient assistance programs. I literally went home and spread them all over the living room floor, trying to stack them up and look at cards and find out who my contact is. Some of the cards were 5 years old. There was just all these things, I didn't know what they were for. So the more I was getting into the role, the more I would ask questions. I'd knock on the pharmacy, try to ask them, do you have this report? Do you have this? What's going on? Who does this role? And that's when I first started working with my FRNs especially. And sometimes it would be a rep in sales, right? That if they didn't have a good FRN person, some of them are very savvy with access and reimbursement. So I realized at the very beginning that they could answer most of my questions than most of the people could in the hospital without having a history in this. And we can get into it more, but I mean, I've become very close. Like some of the people that I've met from the very beginning when we started this role, I still ask them all questions. I still bother them regularly, so.
No, I'm actually going to play off her just a little bit too. So I think that she brings up a great point, is the relationship that's involved. And I know that, again, I can only speak from the private practice side, but these are some of the most important people in my career. You know, these are my go-to people. And I think that that might be a little bit different in the private practice versus hospital, because like you said, you actually had the opportunity to kind of go to some pharmacy or attempt to find answers elsewhere first. And really, we had to rely on these people that were coming to our door. So I think that kind of the difference in private practice versus hospital is that initial kind of one-on-one contact. We seem to have a little bit more of a direct, approach to that. Whereas, I mean, please by all means, I know she's our hospital queen here. So it just seems like that is a more straightforward approach that we could see.
And the one thing I think too that's a good distinction for anybody in here from industry is that yes. I think a lot of times, no matter how well they mean to help everything, and the resources they provide, it feels like there seems to be some confusion too in the difference of how they approach providers in a hospital-based setting versus a private practice. And I think it's important to understand that distinction, but I know for me it was hard because first we did oncology where they were providers in the hospital outpatient department. So we were doing the front end, the access, right, and then working the reimbursement as well, because it was us, the same team that's going to authorize it, look for benefits, look for copay assistance programs, apply for them, or patient assistance programs, and then also work the denials and bill the copays to the end. So we're seeing like how much at the front end we didn't do, and then we took on non-oncology infusions. And that to me was a whole new world, because then it's the providers now sending us the patients. They tried to do an off for the wrong benefit, like the pharmacy benefit, and I realized I had to take that in because I was like, you didn't even authorize it for under the medical benefit, so we're never gonna get paid for this. I just had to take it in. And then I realized with the oncology and non-oncology side, where it's a hospital-based infusion center, is completely different than the referring providers that send patients to us. And I think the FRNs and things sometimes don't know because they just present us all something in one uniform way. But really, if you're the provider or the treating facility, it is completely different, the information we need.
Yeah, so I'm going to give Josh a chance here. I think it's really important that we understand, and I think let's talk FRM. What can FRM do for us, and then also like what can't they do? Because they're I've always said that they're one of the best tools you can have in your networking chest, but at the same time they do have some rules and regulations on what they can do. So I think tell us about that.
Sure, thanks for the question. So I think first of all, it's important to know that the FRM's goals by and large are the same as your goals. Okay, we understand that the healthcare professional has prescribed one of our medications. Typically, if you're talking to us, it's one of ours. And we want to make sure that you have the best experience in getting that, and that we can help you make it as seamless as possible. Our end goal is like yours, a good outcome for the patient on the right medication at the right time, based on the healthcare practitioner's best interests and best decision. That said, there's a lot of hurdles in the marketplace, and an FRM does not necessarily have like a magic wand to wave, but they can offer significant guidance in certain situations. So that can be educating on manufacturer resources, such as the copay programs that we might have available, the eligibility criteria for patient assistance, and any other programs that we might have. Even beyond the specific therapy programs, I know at Pfizer, and I can't speak for every other company, we actually educate on the insurance landscape as a whole, on the IRA and the changes to Medicare Part D design, on how to pick a plan. And we do this through partnerships with advocacy groups typically, whether it's Triage Cancer, Patient Advocate Foundation, professional organizations like ACCC, and really leverage their expertise with our army of FRMs to get those educational tools and resources into the hands of you all, where you can be empowered to do your job the best that you can and hopefully have the tools you need to explain these hurdles to the patients when they're facing them in an adequate manner. I had an aha moment several years ago doing a focus group through ACCC with a bunch of folks with probably very similar titles to everyone in this room. And we were asking about what do you use when you have to talk to a patient about their current insurance or re-enrollment or how to pick a plan or how to enroll in Medicare? And we got a different answer from everyone in the room because there wasn't any kind of standard education. And I think that was a big light bulb moment for us in industry and certainly at Pfizer, that maybe that's a role we can play, is help create some of these educational tools, not only about our specific product and our patient support programs in-house, but also about the general landscape of access and reimbursement. Now, the other question was, what can't we do? And certainly we live in a world of compliance. I think there's more compliance, and for good reason, in pharma than in any other industry, banking, anything else. We have very strict rules and regulations, and that's based on the fact that we always want to be above board, but also because in the past there probably were transgressions by bad apples, and everyone has a little PTSD from that. We really need to make sure that we are sticking to the rules. A couple things bubble up to my mind that we never can do. We can never fill out documents and forms for you, so we can find and point you in the right direction of the information you need, of the documents and the forms that you might need to complete the process, but we can't come in and do it for you because that could be seen as providing extra value, a service that the practice would otherwise have to pay someone to do. We can't come and do it for them because that could be seen as an influence to write our products because we're helping the office out with their staffing needs. So that's kind of a no-no. The other thing is we can advise on the fact that there are philanthropic opportunities aside from copay cards out there for patients who maybe they fall short in their coverage, they have high out-of-pocket, but we have to be very careful about talking holistically about them. We can't point anyone to one fund A over fund B, but we can educate on the fact that there are these funds that exist, and there are several funds that might be open, and then you can kind of check them out on your own, but we cannot direct you to one fund over another fund, kind of like we can't do the paperwork for you. So I think that's sort of holistically where the limitations come in, is we can provide guidance and education, but we can't, as much as we might like to at times, we can't actually hold your hand and do cross the T's and dot the I's.
All right. So I think we all have, a case or a story. I know I have one from just a few months ago. One of my clients, who's a healthcare system out in California, ran across a situation where they weren't able to get free drug for their patient because there was no auth required. And I was like, I'm from Illinois and Michigan, and I was like, what? Why would that be? So I reached out to one of my FRMs from when I worked in Michigan, so one of those very first contacts. And I talked to him, and he's like, what? That doesn't make any sense. And it was his company. But he's like, all the states have different rules, and I think that's another thing is your FRM is going to be an expert on the rules in your state or in their region. So anyways, he reached out, found his counterpart, who was the FRM for that, my client, and sure enough, there's a California rule, and so they weren't able to do that, but we were able to connect my client in California with their FRM. So I think I'm going to pass it down here for everyone. Just think about your most recent patient case that you worked directly with an FRM or somebody from pharma to solve a problem for your patient.
I have way too many to think through, honestly.
Most recent, or the one that comes top.
I think, though, honestly, it wasn't even a patient story. There are a lot of stories like that, right? Even in the prior auth stage, or even in the reimbursement stage, right? I have a lot of examples, but I think one of the really good examples right now of working with somebody from industry is Linda in here? Regeneron? I have, there's one that we had new drugs, very, very expensive drugs that we were giving, which were still under miscellaneous codes and things, and established a great relationship, not going through access issues and also reviewing every single claim for those patients and meeting in person every few months just to make sure we are not really losing so much as a facility giving these new drugs, right? And that it's successful. So like keeping track, and we are still working on several scenarios for these two drugs that are, I mean, well over a year now, still trying to get through it, but it's nice having that resource, right? And thinking of helping research, like if this payer isn't paying enough, or, you know, just going through and having someone else to work them with me. So that's been a great relationship, having that. But it's nice, right, if you don't ever establish that relationship, to be able to do that and actually work through your most difficult accounts, right, and making sure that nobody's having problems with access and you are still getting paid for them.
Yeah, so I'm actually going to kind of copy you a little bit. I would have to say some of the most recent patients I had that were sort of pain points that I needed to reach out to someone to get extra assistance were for free drug programs. I think that, you know, again, as we've evolved over time, some of these rules and regulations have changed, and we're maybe not used to that. We're just kind of used to the older days, and that muscle memory kicks in of how we're used to being able to do things. And it doesn't always stand the same way. So I've definitely had to reach out, and, you know, sometimes it's internal policies with other programs, but just having that conversation and being able to be open with someone, they can even get you in touch sometimes with the next level. And this is where, you know, you can start to make that real change happen and start to influence the actual policies that are written at even these other companies, just by being able to have the conversation and show data. You know, this is how it can affect other aspects of a program and patients. So we want the best access and the most accessible access, but sometimes we have to really work for it. So it's definitely, I have all my people on speed dial. Right. I know that sometimes they may cringe when they see my name on their phone, but every single one of them, you know, is always a text away or a call away. So I think, again, building that, and I love that you said relationship, because, you know, I think we're so geared to say partnership a lot of time. I love the word relationship because that means you can disagree and you still love each other, right? So that means I don't have to agree with your program. That means I don't have to agree with the setup, but that means we can have a real conversation about it and talk it out and actually discuss the problems that exist.
Yeah, and Josh, do you have any patient examples? I know it's been a little while.
Well, I haven't been an FRM in almost 5 years, but I still actually, relationship is a great word because I still get calls from people that I used to work with when I was an FRM. And they know that I've moved on to another role, but they're like, Josh was my guy. He helped me out so many times. I got his cell phone number. I'm going to call him. In my capacity, I also meet a lot of patients. And recently, we've actually heard about some of these, you know, carve-out alternative funding program denials. Was anyone in the session with Joanna from Triage Cancer a little bit ago? Yeah, so the stuff she was talking about, we've seen an uptick in that sort of thing over the last year. And towards the beginning of the year, there were a couple of cases, and even late last year, that were very similar when someone was trying to get one of our products. And we're talking about rare cancer types. We're not talking about sort of a generic anything with very specific targeted therapies that there are not a lot of choices for. And insurance companies were just saying, well, that's not on formulary. You know, talk to the manufacturer about, you know, patient assistance, but the patient wasn't eligible. And so what did I do? I connected them with Triage Cancer. Connected their provider with a local FRM, and through those connections and those discussions, patient was able to get on therapy after they did the proper pushback. So even though I'm not as close to it as I used to be, every now and again it does still come up, and I think it's really important to maintain those relationships with all kinds of stakeholders because you never know when they're going to come in handy.
So now we're going to start talking about barriers a little bit. And barriers have really evolved and changed in the last, I'm going to say the barriers 5 years ago are not the same. It's new barriers and new changes and challenges. So I think I'll talk to Lacey and Melanie. What are you seeing as the most common or most occurring barriers that patients are facing when they're trying to access their treatment? And then, how are you reaching out to industry to deal with those barriers?
So we all know the main reasons, right, for barriers to care for affordability, non-coverage issues and things. There are these programs available from industry, right, to help the patients. I think one of our biggest barriers, because once we have an established team, we're a well-oiled machine. We are very informed. We're keeping up with new indications and everything. Our biggest barrier has been with industry constantly changing. It used to be where this is how you just apply for this program if this is the way it works. And now it's like, no, now you need to tell the patient to go get a printout of their original birth certificate. I'm just kidding. It was like, the printouts of their entire Medicare spend. And us, we're hospital-based, the pharmacy, the patient, all of us are like, we literally don't know what you want or how we get that. And they're like, just ask a pharmacy. Like, what? We have a pharmacy. I don't know a retail pharmacy. I don't know what you want. And there are times where industry just loves to change these things up, and we tell them, we're like, can you call the patient, tell them where to get that? Like, no, you should know. They should know. I don't. That's it. And there's a huge pharmaceutical company, and this happens constantly where they're changing the criteria, the rules of how to apply for the programs. They want you to, saw off your leg first. I don't know what you want. And some of them are really, really hard, and it's very obvious. They are on Social Security fixed income, very low income, and they want proof that you spent $976.27 of something. So that's been our biggest barrier, because we know how to prove medical necessity, get offs, work with payers. Payers do not change their process like industry does. So there's all these programs, but I think that's our biggest barrier, is trying to figure out how to get through, because a program that was working very well, we had a great relationship for 5 years, all of a sudden, completely, there's a huge, I don't know if anybody's in here from this company, but they just got rid of all their FRMs for oncology. They're gone. And it was one of our most favorite companies to work with, huge. It helped a ton of our patients, and now we are just like, why? We have nobody there to talk to, ask questions to. We are hitting so many barriers now for over a year, and we still to this day are just like, I don't know how to help these patients with you anymore. So
No, I think that's a great point. So I think that everybody else out there can probably feel this too, but I feel like we are in a season of change, right? Every corporation, it seems like every company, even our own company, is going through changes, things that, we have to navigate with. It just seems like they're all at once. So that's kind of a newer thing that we're having to deal with. I would say on the barrier side, in the asthma and allergy field, we've been very spoiled. I'll just be honest with you. We've been spoiled. We haven't had to see a whole lot of accumulators and maximizers, and this is something newer to us that we're still having to kind of learn and navigate what the next steps are. So that's been fun. Definitely. I definitely would say that my FRMs, my key account managers, these are the people who, they're getting the first call. Look, I've heard of these things, but I've never experienced them before. What do I do now? Now that my patient has a large bill, what's the next step? Can you help me understand this a little bit clearer until the light bulb goes off for the future patient? So that's really a big step that we've kind of been trying to look at and to see what the next processes are. Definitely agree that, of course, industry rules changes, things like that. We all have that. We all still, again, muscle memory is my favorite go-to word. I like to do things the exact same way because they're comfortable, but it's okay. One of the great things about people who do this type of job is the puzzle, right? So if you don't like puzzles, you won't like this medication access, because it's always searching for the answer and trying to make it fit and make it work. So it's almost like you play the game. And that's very undermining what we do, but it's almost just, like you play the field. I would say payer policies is also a big issue that we encounter a lot, because we have a lot of, I don't want to say most, we have a lot of programs that use buy and bill methods for in-office use. And then, you have to follow these policies in order to understand that if you all of a sudden get denied claims, it's might be because the policy changed and now it's a push to have to use a specialty pharmacy or these carve-out plans that you were discussing. So you also have to, again, sometimes it's an inner working process. You have to really just understand what you're doing as well.
Yeah, and I think one of the things I noticed when I was in northern Michigan, we had a regional plan, mostly HMO, but they also were the third party for all of the self-funded plans in the area. So when we started noticing copay accumulators, I talked to my FRMs and they, it got to a point where, because you can't tell when you look at an insurance policy if this plan has an accumulator or a maximizer or an AFP, you can't tell. They're not out there advertising it. So it was one of those things where the FRMs are getting to know because they're reaching out, they're talking to each and every one of you in the offices and at the cancer centers and healthcare systems, and they're learning, which self-funded plans are doing what, and then they're sharing that. And so I wanted to give Josh a chance to tell us a little more about, some of that networking that you're able to do just because of the relationships you're making throughout a region.
Sure. Is there anyone here from the cartels? I mean, the PBMs in the room? No? Okay, good. So we can speak freely. First, I want to address what was said earlier, and before you get your tomatoes out, I've never personally made a decision on changing eligibility criteria, so don't shoot the messenger. What I will say is, you're right, eligibility criteria has changed. What was described earlier about the different documentation, I mean, look, if you're not bringing me 3 puppies and your firstborn child, don't even apply. No, that's a joke too. But it is a bit of a cat and mouse game with the PBMs. And when pharma companies make these changes to eligibility criteria, it's not just because they want to be more ruthless or want to be more profitable. It's probably because their hand was forced by changes in the marketplace. So when you talk about these AFPs, what happened was a lot of pharma companies had these very generous patient assistance programs. We didn't want a denial to stand in the way of the patient getting on the medication that their healthcare provider thought was the best choice for them. And so we asked, do an appeal. If that appeal is denied, okay, either you're in, or maybe we ask for one more appeal depending on the company, and then you can probably come in. Well, these PBMs got wise to that, and they said, all right, well, we're just going to cut an entire group of specialty drugs off because send everyone to manufacturer programs. They're all going to get on free drug anyways, and we don't have to pay for it. The patient's not going to suffer. They'll get it from the manufacturer. That started happening a lot. And when that starts to happen, these programs, which were meant to be for patients who really are in need and don't have coverage, they start to become unsustainable. And so pharma often will change the eligibility criteria. The same thing could be said with copay programs when you talk about maximizers and accumulators. When those were little known words that you asked 5 people in a room and only one of them had heard of it one time, it wasn't such a big deal. But in 2024, I saw a statistic that I think it was 76% of plans out there had language in them that would allow for accumulators and maximizers. Now, they hadn't all 76% enacted that this year, but they had the language in the fine print, which, Clara mentioned it's really hard to know if you have one of those plans. It is, unless you have been to law school and can digest the fine print and understand what they're saying. And they do not write it clearly either, and they do that for a reason. I'm not trying to place all the blame on PBMs and payers. It's a very complex system, and everyone has to sort of make their bottom line. But this cat and mouse game, unfortunately, lets the patient be caught in the middle. And I think that's why it's never been more important to work with your manufacturer, work with your FRMs, let them understand the hardships that you're facing, and so they can hopefully run that up the chain and find solutions. And we're doing that at Pfizer. We're not the only company who's trying to be innovative on the way that we push out our free drug programs, our copay programs, because we understand that while those changes were made for a reason based on the marketplace, there have been unintended consequences, and we're learning as well. So please keep those lines of communication open. Now, to your question about networking, from where I sit, I talk about networking with the healthcare providers, but also with the advocacy groups, because there's a lot of support out there that doesn't come from manufacturers. It comes from local, regional, and national support groups. And whether you're able to get that information from someone in your office or from your industry counterpart that you work with, that's an amazing resource that if you haven't tapped talk to someone, either your supervisor or your FRM, and see what they can tell you, because there is a lot of free education out there, but there's a lot of actual financial resources too that can go to help patients. And I know I'm probably preaching to the choir in this group. You guys probably know more about this than I do. But I think from a networking standpoint, the more that we can make those connections for local, regional, and national resources for when patients really do face hardship, the better off they're going to be. And some great groups already collate that information, whether it's Patient Advocate Foundation or Cancer Care or others. I'm in the oncology world. I think a lot of people are, but if you're not, excuse me if you're not as familiar with some of these groups. The next frontier, I think, is technology and AI. And this is something that we're actually dabbling with at Pfizer, and we're not the only ones out there, is how can we take this massive amount of information and this very laborious process of trying to find resources for patients that are available and that they qualify for, and then track them down. That can be hours of time that you're spending on one patient case. So the next frontier is, I think, going to be the use of technology and AI to take these large data sets, if you will. I mean, data set doesn't have to be a statistical analysis on big numbers. A data set is anything. It's where resources are, how much money is available, what's the eligibility criteria, and boil it down, and within moments to minutes, be able to take that 2.5 hour process that you did before manually and tell you what this patient can find, where to find it, and what they're eligible for. Now, we're not quite there yet, but we're getting really, really close. And so, I always say, what's the one area where technology has made work harder? It's the medical industrial complex, right? Between all the EMR and the promise of that from the 90s and when they first started talking about it and on, it's created processes where you have to then hire more people to figure out these processes. I think we're at a tipping point where the pendulum is going to swing. I'm hopeful of that. So stay tuned. More good stuff is coming, but I think that's going to be the next frontier in resource allocation and financial navigation.
Great. Okay, so we're going we're tracking a little off, so we're going to go quick on this next question. But just talk about some of the patient support programs that are available through pharma. So maybe I'll let Josh get started here. And, what are some of the things other than just a relationship that are available through pharma? And then, ladies, I'll let you talk about, how you've used them and how you decide, which patients are right to go and use those different programs. We'll try and do it in like 5 minutes or less between all three of us.
Careful letting me lead off here. I might be a little long-winded, but I'll do my best. So look, everyone I think knows we've got your basic copay programs, we've got manufacturer assistance programs, we've got hub services, which if you're interested can do some prior auth research, although you could probably do it faster, frankly. One thing that I would love to highlight, I've mentioned a couple times these partnerships. We have a website that we co-developed with Triage Cancer called My Healthcare Finances. It's myhealthcarefinances.com. Check it out. It's totally free, and when you talk about education for providers and for patients, this is a place where you can go to get unbiased. There's no products. It's not about Pfizer. Yes, our logo is there. It's a Pfizer-owned website, but it's all about free information. And again, the idea behind this is that if you have a patient sitting across from you and you're having to talk about these complex topics and make them understand about a copay accumulator or the changes in Medicare Part D design for the IRA, or how to pick a plan if you're commercially insured, or what's self-funded versus non-self-funded, or how to pick the different parts of Medicare. It's a great place to go where everything on there is view, print, share. I mean, you can view it online, you can learn about it, you can send it to someone, and you can print it off and show the patient sitting across the table from you. So that's my plug on that, on resources available from industry, and I know time is short, so I'll pass it along.
One quick thing about Pfizer is, last time we had our summit last year, I asked our team if they had feedback for all the sites, and I did pass on this feedback, and it was funny for Pfizer. I told them, I said, your application is microscopic. I said, you could type it, you could handwrite it, doesn't matter, but we have critical access hospital, community health hospital, we've got 2 states, providers that move around, and we handwrite it in the central, or we type it in the central office. We have to get the patient to sign one of the copies. We have to get a nurse or somebody to get the provider to sign another. They fax it back to us so we can fax it in, and you cannot read any of it. So I was like, your app, why did you want to condense it onto one page? It was just, there was several people, and it was hilarious because like a month later, they were like, hey, the Pfizer app is so much better now. And I was like, yay. See, so like, you gotta be able to talk to them, get things done. But so what I was saying too, with all the criteria that changes and as a barrier, I would suggest too, and if it's industry in the room too, working with providers, or if you're representing a health system or the provider side, I think one of the things we like to do is if there is a new FRM or whoever is going to be our point of contact for things like this, from a new drug we're going to start using or whatever pharma company, right, we're working with, we kind of grill them. We have them meet, usually in person. Sometimes it's remotely with COVID and stuff. We have our team now are not all centralized, so sometimes it has to be online. But we used to love to get them in the room so we could ask them questions, because first we're gauging how much we're going to use them. Because I literally meet some of them and I'm like, oh, they're so confused and they're reading the slides, right? And then I will go back to an FRM from another company for help, and I'll just say, hypothetical question, what would I do in this, or how can you help me? So, but the main questions we ask though, if you are in a smaller practice, it's easier, but if you're a hospital and you're doing oncology and non-oncology, when I say the criteria is different, I would suggest that you get somebody who loves details and literally start making a database or a spreadsheet, right, old school, so we have to maintain this for every drug, and I mean, there is like 60, 70 programs we have to track of just everything. So if it comes to copays, do they allow you to do an application and retro? Will their copays cover if you apply for it 90 days after they've started their date of service? Is there a rule about how long until you have to submit your first claim? If it's patient assistance that they will need, what's the criteria that they will have to show for it? Does it retro? If it's by the time you get a claim denial, will it even help? Or is it based on the day that the application is signed? Is it, there is about 50 questions of us just how to even utilize their program. If you don't know that, right, how are you even going to access these programs, right, sometimes? So, and it can be accessed at the front end during authorization, or at the back end if it was authorized but they deny it for medical necessity. And do they require a denial before they will do it? Did they require that this application was signed before they ever got that first treatment? Some yes, some no. There is so much, and I think that most providers really lose out on so much assistance if you knew it. Like if you know the companies that will retro it, don't require an appeal, or this is their process, right? Then how could you not use those programs to help later, right? To help after the fact. How do you know which drugs to always make sure you have an app sign to cover your bum for? Which drugs should you always, like this drug we buy for $50,000 every time, right? And we should always get this app in place because that's the only way we will get help in case we never get paid for this. So we maintain all that information, and it changes. That's what changes all the time, right? We don't retro no more, or we don't have replacement anymore. That is, if anybody, if you're from industry, I suggest you pass all that information to all of your clients because it is very helpful. And also if you're from the hospital side, try and get that information.
So I think that probably the most common programs that are offered with the manufacturers that we work with, of course, are going to be our copay assistance and our PAP programs, or our patient assistant programs. There are also nurse support systems available. We don't typically use them as much because we're very hands-on, kind of like, I think certain organizations are very hands-on in teaching, but they're wonderful programs, and they're available. I think sometimes they're probably not advertised as much, but they're definitely available for everyone. But yeah, copay assistance and PAP programs are sort of our go-to.
All right, so now we're going to transition to building these relationships that we've talked about. And I think one of the things, there's probably some people in this room that they've got relationships with their field reimbursement managers. They know who they are. There's probably some others who are considering developing these relationships further, but need to know how to find their FRMs. So Josh, maybe I'll pass it way back down to you. So this is Pfizer specific, but is there a way for a navigator or an advocate to go and find out who their person is if they haven't been, hopefully the FRM has reached out to them, but if they weren't able, to meet up, how can they find out who their person is?
Yeah, great question. So some companies, if you go to their like patient assistance program or copay program website, some companies will have an option to find your local FRM when you put in the zip code. But probably the most direct way is, I guarantee if you don't know them, there's someone in your office who knows a sales rep for that company. And the sales rep will know who the FRM is. So that's maybe the most direct way. The sales rep, those are those people bringing all the mess of literature that end up in the trash can every day. That's the person you want to talk to, no, just kidding, and find out who the FRM is if you haven't made that connection.
And then I think I'm just going to keep it on Josh, because it's all about how do we find you. I think the other thing is you've probably experienced some challenges reaching out to the people that need you in hospitals, healthcare systems, and provider offices. So what kind of challenges have you run into, and how can we work to solve them so that we can develop the relationships?
Well, I think sometimes, and this happened to me early in my tenure as an FRM, you don't know who the right person is. There's a lot of staff members, and a lot of them have very similar titles sometimes, not always. And it's knowing who is the right person. I mean, one office in particular, I remember, I think I gave like 10 presentations there before I realized I was presenting to the completely wrong people who are actually dealing with the stuff with the patients that they want to come in contact with me. And, a pharma lingo term is like the total office call, making sure that you're speaking to everybody, understanding the roles. But if you have especially a new FRM who's coming in, and you come in contact with them, take them by the hand, figuratively, and guide them. Who's who in the office? Who should they be in touch with? How do they schedule an appointment? Who does the buy and bill? Who does the oral prior auths? Who does the manufacturer assistance? That could all be the same person. It might be several different people. So, we want to help, but sometimes we don't know who to contact, and we would rely on you all to help guide us, because no one knows your practice better than you. And all the practices we go into, they all kind of blend together at some point if we don't have a little guidance there.
Okay, so now future. And I think we've talked about this a little bit. We're in a season of change. There's a lot going on. I think we even have some big changes coming in January with Medicare and like smoothing and that kind of thing. So my next question is, what do you see as emerging trends or opportunities for improving collaboration between industry and financial advocates?
So I mentioned the tech piece earlier, and I think this is getting close. I know we're working on some stuff at Pfizer, and I'm sure we're not the only ones. And also there's great, third parties. I mean, that are specific to finances, TaylorMed, Atlas and Nexus. These companies all do wonderful work. But even beyond some of the stuff that they do, I think the technology piece and the AI piece in particular is really going to take us to the next level. But anything that we are going to try and create in pharma or fund the creation of through partnerships, if we can't work with y'all and test it out and find out what's good, what's bad, what you like, what you don't like, it's just going to be a piece of crap, really. I mean, frankly, that's the truth. We need input from the folks who we hope would use it, and it would improve your professional lives. So I think that's going to be a real opportunity for more collaboration moving forward.
I was going to say, if they would use us more to collaborate with, because before you make them bake you fresh croissants to get their patient assistance program, you could ask us, is that possible for them to bake? And they'd tell you no. So I wish that they would collaborate more with front-end people to say, like, hey, we changed our program. Is this even possible? No, I don't even know what that is. This patient doesn't know what that is. But there's a lot of things that I feel like we ask, and sometimes the FRMs don't know what to do. And right away, I want to start building that relationship, and I'd be like, okay, this is what I believe you as an FRM should help us do. And they're like, can you call the hub? And I was like, no, I called the hub. I'm having problems. That's why I'm calling you. Can you help us, please? And I've said the words, I'm like, isn't that your job? It's your job to do that. I was like, I don't understand what your role is then. But we want those relationships because we want a good point of contact. We rely on them to educate us things when there's updates too, but we also try to give them that information And we do communicate too. If there's something that we have good relationships with them and we are asking for like unbranded education, those resources, we ask them and they sometimes will deliver. They came and educated all of our team right on just breast cancer so that they understood as financial navigators the clearance, right, of like all the different types of biomarkers, everything just unbranded. And so they provide so much education, right? And it saves you the time of having to educate your team on all this information. There's many ways for this role in the future. I think every pharmaceutical company is different, I think, too, on how their FRMs, their internal processes, how much they work with other people to get information. I hope in the future it really does expand, because some of them I don't know who they're getting to help write their reimbursement guides, or like I don't know where they're getting this information, but you should ask for more help. So hopefully we collaborate more.
Yeah, so I agree with both of them. That's, you know. So I definitely would say, again, having the relationship to begin with is where a lot of that feedback, I think, is very personal, because then it's a trusted feedback, right? It's not just something that's made me mad on a Monday. It's actually, this is going to be a concern when it comes to access. This is going to be something that's going to be a longer issue. So I think that, again, is one of those things. If you don't know who your person is, when I talk to a lot of offices, one of the big things I hear is, well, my person doesn't come around, or I don't know who they are. Don't be afraid to reach out to them. Don't wait for them to come to you, because, again, they don't know you exist yet. So sometimes we have to make that first step, too, and say, hi, I'm here. I'm your new best friend. You know, come see me and let's have lunch and let's discuss things. So I think, again, just being able to keep an open mind of saying, you know, I know that these people exist out there, and if I don't know them, I'm going to find them. If I can't find them, I'm going to find someone who's going to help me find them.
All right, so I'm just gonna kind of conclude here. Sounds like what we're looking for is more communication, better communication. And since every pharmaceutical company is different in what they can and can't do and how they do what they can do, I think it's really important, you know, if you're from pharma and you're in this room, make sure that you're getting to know all the people in your region. And then for all of us advocates, you know, take the time to meet these people, take the time to develop the relationships, because they do reach out, they do round tables. You know, when they have a new drug or they're working on a project, they do reach out. And the more you have a relationship with your FRMs, the more likely you're going to be asked to be a part of that too. So I think maybe what we'll just start with Lacey and run back across with, you know, like what you think, you know, the audience should take from today. And then if we have a couple of minutes, we can take some questions.
Yeah, so I'm very simplistic here. I think, again, I get the chance to have the conversation. Don't be afraid to say, this is how we work in an office, and this is, you know, what I need from you. At the same time, understanding that they may not be able to give you a wish list. You know, again, just kind of that open mind, but continue the conversation. Don't take a stressed out Tuesday afternoon as this is life and that's the way I'm going to speak to you forever, and kind of make that the way it is. It's just, there is a actual relationship to be filled, and I'm truly serious. I mean, these are the most important people in my day-to-day work, and so I don't know that I could do it without them. I really don't. And from the beginning of my career, these were the people I relied on. So I was very lucky to have people who always was there for me. But I have met people who did not have that, and so it was kind of that point that you had to get to almost overcome yourself of saying, I'm going to reach out and find who my person is, and then things went better. So I think that, again, if you're not in a position where you have a great relationship or you don't know anyone, take the opportunity to research it and find somebody, and then, you know, build that relationship. The one thing I want to harp on, and I don't even want to make it sound ugly, but if you don't have a good relationship, okay, if you're not getting along, if something's just not clicking well, because not everybody clicks well, don't be afraid to ask for someone different, because that is a possibility. You can have people that can change into those roles. Then maybe it's just a personality thing, or maybe you're just not meshing well. And then all of a sudden, things go much smoother for both sides, for pharma and for the office.
I just want to say, if you do have that lookup tool to find out who your FRM is, any companies out there, and it doesn't actually take you to the person, that's mean, take it off your website. Because there are some where it's so amazing to go on there. It's like, who's my FRM? You click on it, it says, what's your zip code? And is this oncology or neurology? And then a picture pops up of your FRM and his contact info. And there's sometimes where it's like, who's my FRM? And you click through it and it's like, call the hub. And they don't tell you who any of your FRMs are. And I'm like, why? That's just mean. I don't want to call the hub and talk to them. I want to talk to someone right now because it's a very complicated issue. So I don't know why people do that. But I will tell you that it is really hard to find some of the FRMs. Honestly, for us, we have a hard time. But like he said, though, ask sales, because they will know who their FRM is. I think that's been the easiest thing. I would call the pharmacist. But I am from a hospital setting. I just want to say there was a talk before this from Advocate Aurora Health. They gave very similar examples of how they actually utilized FRMs as well, very similar to us. And I think if anybody here is from a hospital setting and you have questions about the different ways to utilize this relationship, please come find me and chat, because I know there's very different groups here. But there's, honestly, this could go on for hours, talking about all of the ways that we can work together and things have become helpful.
Yeah, it was hard to even put the questions into like a 1 hour.
Well, speaking of that, I think we're at time now, so I will just quickly say thank you for listening to this talk. Thank you to my fellow panelists. Thank you, Clara. Thank you, Haas. I don't know if we have time for audience questions, but I have nothing else to say. Thank you.
We have 4 minutes. Okay, wow. I was gonna say no. Well, now everybody gets a quick 4-minute break. Oh, go for it. Yeah, I think I've heard FRAD, like Field Reimbursement Access Director. I mean, there's directors, there's managers, yeah.
It's a good point. Anybody else? All right.